Okay, good. So it's a real pleasure now for me to, everybody knows Shelley McMain, and it's a real pleasure now to say a few words for introduction for our presidential address. Shelley is an associate professor in the, is this better so? Okay. Can you hear me? Okay, excellent. So Shelley is an associate professor in the Department of Psychiatry at the University of Toronto in Canada. She's the head of the Borderline Personality Disorder Clinic and the clinician scientist at the Center for Addiction and Mental Health in Toronto. She's a practicing psychotherapist, a trainer, an educator, and researcher. And Shelley is also a certified DBT individual and group therapist and currently serves on the International DBT Strategic Planning Committee. So as you can imagine, Shelley's interest is on personality disorders, DBT, emotion regulation, suicidal and self-harm, and behavior and substance abuse. And of course, she has authored many, many papers, done many, many lectures, especially here at SPR. So you're a long-term member of our society. She just told me that Jeremy Safran was like the first contact you had with SPR, and that brought you to SPR a long time ago. And I'm sure you will mention this and the history. So I'm really very, very happy to have you here, and we would wonderfully work together. So Shelley, the stage is yours.
Wow, 3 years since I've seen many of you. It's incredible to be here in person and to actually be looking at an audience and not standing in front of a Zoom screen giving this talk, because I don't know, if I had to do another presentation in front of Zoom, I'd have to hit my head on the screen. I've really missed actually seeing everybody, so it's just great to be here. And I'm sorry there's many people who couldn't make it in person given the COVID situation, unfortunately. Hopefully next year. I'd say there was only one downside in doing this in person as opposed to Zoom. I actually had to coordinate what am I going to wear on the top half in addition to the bottom half. So it's been a while, I know, since we've dialogued in person. But I'm wondering if you can remember the last time that you were bantering with somebody or debating with somebody about some theoretical orientation, or perhaps whether a particular approach was a valid research approach. Maybe it was yesterday, for example, with somebody, or maybe it was the last time you were at a virtual conference and maybe there was chat on the Zoom chat, between you and somebody else. Or maybe you might recall back to being at a conference and going out in the hallway after a really controversial presentation and having some debate with somebody else. So, or of course, you might have taken it to another level and published your very strong opinion in a letter to the editor because you felt strongly about your side of an argument. I think these academic debates can be incredibly valuable. I think they provide us with opportunities. And they provide us with opportunities to see another side. So my talk is on embracing dialectical tensions. In other words, embracing different viewpoints. I think it's a way to advance the science of psychotherapy in general, and more specifically, I'm going to be focusing on psychotherapy for personality disorders. So my plan for my presentation is as follows. I want to very briefly talk about a dialectical lens and how I think it's useful for understanding how we advance progress in research. I'm going to introduce the context for my work and my research. I'm then going to talk about research related to a general approach, and then research related to tailoring psychotherapy. And then finally, I want to touch on the issue of access to therapy. And within each of these broad topics, I'm going to be sharing my perspective on some signature dilemmas, and how a dialectical lens, I think, can help us consider how we can make progress. I'm going to be highlighting my research. I'm also going to be highlighting some research of others. And specifically, I'll be focusing on my research in the area of personality disorders. So 25 years ago, it was at least 25 years ago, I gave my first Grand Rounds talk at the hospital where I currently work. A little nervous at the time. I remember at the end of the talk, there was a very senior, eminent psychiatrist sitting at the back of the room. It was a room like this. And from the back of this full room, he yelled out at the top of his lungs, "There's nothing that you're saying that's new here. We know all this. We've been doing this already." I was actually a bit taken aback by his tone and what he was saying. But the truth is he was right, actually. In fact, one of the things Marsha Linehan always said to me was that she stole all the best ideas from other therapies and she just put them into one package. There's this sort of dialectical process, I think, the way that we advance science. Of course, there's many views on how science advances. And a 19th century view is that of George Hegel, actually the former chair of philosophy at Heidelberg University. And Hegel proposed a dialectical view of change. And he argued that truth is found neither in the thesis nor in the antithesis, but it's in the emergent synthesis, which reconciles the two. So many philosophers have since advanced the idea that science progresses dialectically. And I'm going to apply this lens to the advancement of psychotherapy research. So I think a central dialectic, and the first one I want to highlight, is the one that surrounds clinical practice and research. We often hear clinicians complain that research isn't relevant to their practice, since research may not be interested in clinical practice concerns. And at the same time, we hear researchers complain that clinicians really are behind the times and they're not using the literature. I think ideally any really good research study is motivated to address a real clinical problem. We start with the clinical problem. We're not in this, hopefully, just to publish a paper or just to get a grant. A defining characteristic of most advanced sciences is that it really is addressing a significant clinical issue or significant problem, rather. Once we identify the problem, then this is acted upon through the research activity. So we theorize, we reflect, we use a systematic approach to investigate the phenomena, and then things don't stop there because we bring the research back to the clinical problem and we figure out, does the research apply to the clinical problem? Is it useful? What's missing? And with each solution to the dialectic, a new problem arises. And this transformation it occurs through a dialectical process. So briefly, I want to say a little bit about my research focus, just to contextualize the work that I've been involved in. A prominent personality disorder researcher once told me, "You're someone who doesn't subscribe to any one church." And I don't know, when he said this, I wasn't sure if that was meant as a compliment, but I took it as one. There's been a lot of factors that have influenced my research focus and my discomfort with any one perspective or any one method. Of course, family plays a role in shaping all of our behavior. My family didn't have any concept of what it meant to sit in silence at the dinner table. Most, evenings of dinner night conversations usually resulted in some debate about a range of topics. And in that context, I really learned to hone in, pick holes in theories and look for inconsistencies. Of course, there's a lot of other people who've influenced my interests and my work, and I'm going to highlight just a few significant people. One of them is Jeremy Safran. So Jeremy was my first psychotherapy supervisor, and actually the main person who introduced me not only to SPR, but really being engaged in psychotherapy research. I collaborated with him on the first Alliance Rupture Repair manuscript. We wrote a paper together on CBT for clients with personality disorders. So he was quite instrumental to my interest, not only in the Alliance, but also in working with some challenging individuals. I also was very much influenced by my supervisor, Les Greenberg. So I did my PhD under his supervision, where I was exposed to common factors and also emotions, of course, and psychotherapy integration. And Les was the person who introduced me to SPR as well as SEPI, along with Jeremy. And he was, it's really, I think, as a result of both of them that I met many of the colleagues here I now consider good friends. And then as well, I started a position in the Addiction Research Foundation after I finished grad school, was working predominantly with clients with personality disorders. And I reached out to Marcia Linehan because I felt I was lacking really ideas about how to work with the clients that I was treating. And Marcia really became a lifelong mentor to me and source of support in my research and in my practice. I define myself as a clinician and a researcher, and my work has always developed within that context. So I've been working at the Center for Addiction and Mental Health. It's a large teaching hospital affiliated with the University of Toronto. I oversee the borderline personality disorder clinic there. So many of my research studies have developed in the context of my work at CAMH. Some of you may not work with clients with BPD, but if you do, you'll know that they're notoriously complex and challenging. They have high rates of comorbidity. So we talk about working with somebody with BPD, we're really talking about complex comorbidity. These are clients who are also very prevalent in clinical settings, but despite their prevalence, they tend to be routinely overlooked, not only in research funding, but also in research activity. So to this point, this figure actually shows the number of psychotherapy research publications on various mental health problems published between 1980 and 2021. You'll see here that 83% of all psychotherapy research publications focused on depression and anxiety. And it's a figure that's considerably higher than the 55% global prevalence of these disorders. Here you'll see publications, these are psychotherapy research publications on personality disorders, accounted for 7% of the literature. This is despite the fact that in clinical settings, personality disorders account for 15 to 20% of individuals. In another example, so the Alliance, this is one of our most investigated variables in psychotherapy. The recent meta-analysis by Christoph Flukiger included 295 independent studies on the Alliance. Of these, 3%, so a total of 152 patients, were patients diagnosed with personality disorders, individuals whom we know generally are notoriously difficult to engage with in the Alliance. So this brings me to my second dialectic, and it surrounds the issue of who's our research really representing and who's underrepresented. You know, many people have commented on the fact that the psychotherapy research is dominated by our focus on weird people, Western, educated, industrialized, rich, and those from democratic countries. Whereas other populations, more ethnically diverse, non-Western, low socioeconomic status, complex and severe, are not well represented. And it's important because these are the populations that really face the greatest barriers to accessing adequate care and appropriate therapy. So I think it is legitimate for us to ask the question of how well does our psychotherapy research evidence actually apply to underrepresented populations? So our communities are increasingly diverse. You know, the world is more global. I think the lack of diversity in our samples is a lost opportunity to increase our understanding of psychotherapy. for research to be generalizable and to be clinically relevant, I think we'd all agree that research really does need to be sensitive to the needs of the very diverse clients that we're working with. So in my next section here, I want to consider the selection of a general treatment approach. And here I'm going to shift my focus from general personality disorders to borderline personality disorder. First, because there's very little research on other personality disorders other than BPD. And second, because I want to be explicit about the fact that my research is almost exclusively with clients who have a primary diagnosis of BPD. So to contextualize this conversation, I want to consider a client, and I'm referring to him by the name of Robert. Name and picture have been changed. So this is a 36-year-old male. He's been diagnosed with major depression, borderline personality disorder. In his words, I've been on a roller coaster over the past few years. It's ruined my relationship. I've been on numerous antidepressants prescribed by my psychiatrist. I recently had a course of ECT. I don't think it's doing anything for me. I'm not seeing any progress and I'm losing hope. My psychiatrist recently wondered if DBT might be helpful. You know, it's sad, but it's not uncommon for somebody like Robert to have had many years of engaging in treatments that aren't helpful. And so this brings me to a third dialectical tension, and the tension is what's known and what's unknown about selecting an effective treatment approach for somebody like Robert, somebody with BPD. So a recent Cochrane review identified that there's now 75 randomized control trials on therapies for BPD. In total, 16 different models have been evaluated. DBT and mentalization-based therapy account for the highest number of trials. In fact, DBT accounts for 1/3 of all trials. In terms of what do we know about the effectiveness of these trials? Well, these BPD-specific therapies are more effective than non-specific treatment in reducing borderline severity, in reducing self-harm behavior, depression, and also improving psychosocial functioning. The treatment effects you'll see, they range from small to medium across a broad range of outcomes. And usually, you know, post-treatment, 60% of people will have achieved BPD diagnostic remission. So this is a good news story. Now, what do we know about the comparative effectiveness of psychotherapies for BPD? Our group was one of the early RCTs to address this question. And I want to say a little bit about what motivated us to do this trial. So this was in the early 2000s. At the time, there was very little research on psychotherapies for BPD. There were 4 trials on DBT. 3 of them were conducted by Marsha Linehan. So there was a lot of criticism, although interest in DBT, the criticism was there was no research really, very little conducted by an independent investigator. The sample sizes were very small. And then on top of it, DBT had never been compared to a strong comparator. So there were valid critiques of the literature. The other challenge, of course, is that, you know, this is the early 2000s. I was working with a lot of clients with personality disorders. We had no systematic approach. And it seemed premature to perhaps do a larger scale training of therapists and implement a new model when we weren't really confident in whether or not this would be an effective approach. So it seemed reasonable to address the limitations of the literature and engage in a study evaluating the effectiveness of DBT. We wanted a large trial. We wanted it to be compared to a strong comparator, but that's where the next problem came, is that what would we use as strong comparator? There was one other study that existed at the time, an RCT, mentalization-based therapy, and it was a day treatment program. Now, the American Psychiatric Guidelines had come out, guidelines on the treatment for BPD. This is the early 2000s. There was a lot of criticism of these guidelines, and the main criticism is that they were misleading and inaccurate. They are actually pretty valid criticisms. Most of the guidelines, I mean, it seems premature to publish guidelines when there's almost no research. So they were mostly opinions. And the opinion was that really, I would say, strongly biased towards a psychodynamic approach. So we thought this would be a great opportunity to test the guidelines. We couldn't figure out what other comparator to use, so it'd be great to use this. It just so happened we also had somebody in Toronto who was practicing really more of the psychodynamic approach, largely based on the work of John Gunderson. So this study was a randomized control trial. It involved 2 arms, DBT compared to what we called good psychiatric management. Somewhat of an unfortunate name I later, because I think it got misunderstood as really a treatment as usual or a non-specialist treatment, which is what it's not. But we were trying to capture what the guidelines were apparently representing themselves to be. So this was a 1-year treatment with a 2-year follow-up. Self-harm was our primary concern. It was a primary concern because self-harm is of high magnitude in this population, and it's also a great public health concern. What did our findings show? Our findings show that actually both groups made significant improvement across a range of outcomes. There were no differences between groups at 24 or 36 months. And you can see in this figure on the right, in terms of clinically reliable change, this is based on the SCL90, 2/3 of the sample had made clinically significant change. So since our study, of course, there's been other comparator trials. So what do we now know about the comparisons of psychotherapies to other strong comparators? There's actually very few head-to-head comparisons. I would say all of these are superiority trials. So there's no trials that have tested for equivalence. The findings of these studies indicate that there's no evidence to indicate the superiority of one specialist approach compared to another. And these findings have inspired best practice guidelines. There's several best practice guidelines on the treatment of BPD, now recommending several specific forms of psychotherapy, and also recommending that psychotherapy is really the first-line treatment for people with BPD. And this is important because, of course, that wasn't what people were saying in the 90s. They were saying this is a population that's not treatable. So this was very important. And also the effect sizes for psychotherapy trials were much larger than for pharmacotherapy trials. So it's still the case that psychotherapy is recommended as the first-line treatment. Now, BPD-specific therapies aren't a panacea. You know, you can see from the effect sizes that I shared, they're modest. We also know that 40% of people don't improve. We know that many outcomes don't meet the cutoff for clinically meaningful improvement. And we also know that even after a course of treatment, at least half of all patients still have significant psychosocial functioning. So if we bring this information back to somebody like Robert, well, it's not surprising that he's not benefiting from numerous pharmacotherapy trials or his ECT course. And it's wise his psychiatrist is recommending a validated approach like DBT. I think it's likely he would benefit. Of course, he could also be a non-responder. He might just as well benefit from something like mentalization-based therapy. I would anticipate that after a year of therapy, he's still likely going to be struggling in terms of his social and occupational functioning. So there's no question, research has dramatically changed our understanding of what's effective for people with BPD. And this is an incredible story. So we know it's a treatable condition. It's a good news story. And at the same time, although there's been this exponential growth in trials, a recent review concluded that the evidence base just doesn't reach sufficient evidence. And so there is a need still to generate efficacy evidence, not only on BPD, but other personality disorders other than BPD, and as well on adolescence. It's a prime time to intervene when people are young. So let me turn to the next section, which is tailoring psychotherapy. So after we validate a psychotherapy approach, the next task is to improve it and figure out how can we make it more efficient? How can we make it efficacious for the individual client? And I want to contextualize this conversation by considering a client that I've named Norma, again, not her real name or picture. So Norma is a 37-year-old woman with comorbid BPD, substance use, PTSD, and ADHD diagnoses. She's 4 months into DBT treatment. She's missed half of her DBT skills groups. She frequently misses individual sessions. On several occasions, she arrives to sessions intoxicated. Her life's chaotic. Most of her friends are drug users. When she does show up in a therapy session, she's often either vacillating between an angry state, angry outbursts, or in a hopeless suicidal state. She's working with a very experienced therapist, but frankly, the therapist is feeling burnt out, given that the client's making very little progress. So a fourth dialectical tension concerns our level of analysis and selecting the best approach and intervention for the individual client. You know, some research is, of course, much more focused at a macro level. And usually this involves studying variations between therapies or group level analyses. And other research is much more focused at a micro level, trying to capture the individual variability. And especially important in the context of BPD because there's considerable heterogeneity in clients with BPD. So we all know there's many approaches to trying to advance an individualized approach to therapy. And they include, but they're not limited to, identifying predictors of treatment response, moderators of treatment response, and also examining processes and mechanisms of effective therapy, and also mechanisms of psychopathology. So what do we know about predictors and moderators of treatments for BPD? We have a systematic review underway that's looking at predictors and moderators of therapies for BPD. We've so far identified, well, the total count is 300 studies on this topic. Now, there's lots of different ways to characterize clients. If we think of a biopsychosocial lens, there's a lot of different ways. Nonetheless, although there's many ways we can characterize patients or clients, 95% of the studies we've identified have exclusively focused on psychological variables, and only 3% have focused on biomarkers, genetic markers, or neurofunctioning. So the majority of these studies are self-report, and they're primarily focused on predictor variables. There's very few studies on moderator variables, and most of them, of the few studies, are focused on single moderators. So our group has been involved in conducting studies on predictors and moderators of treatment response. And I want to summarize here research that we've been engaged in, but also highlight research that others have been engaged in the field. There's a few broad findings. So if we consider sociodemographic factors, there's actually very few sociodemographic factors that predict treatment response, with a couple of exceptions. Low education and unemployment have found to predict much poorer treatment response in specific therapies for BPD. I think this finding is important because I think it underscores a point I made earlier in my talk, that I think one of our greatest gaps in knowledge in therapy concerns economically underprivileged populations. If we consider environmental factors, a history of childhood trauma has consistently been found to be a predictor of poor treatment response. And finally, if we consider clinical factors, comorbid PTSD, generalized anxiety disorder, and comorbid personality disorders have been found to be associated with poor response. So the finding that PTSD and comorbid BPD are associated with poor response has actually led to the adaptation of DBT in recent years to address those comorbid PTSD in the context of BPD, with, I would say, much better results. So obviously there's a lot of ways that we can understand how to individualize treatment. We can also look at differential treatment responses to better understand how to tailor interventions. In this study that we conducted, we used growth curve modeling to identify patterns of responses in the frequency of self-harm behavior. So this was a secondary analysis of our DBT versus GPM trial. involving 180 people. First off, there was a very small group, so about 7% of people. They were fairly slow to respond, but they ultimately recovered. Our largest group was a group that we refer to as a rapid recovered group. 77% of clients, they improved rapidly and they maintained their gains. And then there was another small group, and we refer to this group as a rapid response group, but they relapsed. So of course, our interest was, well, what were the characteristics of these subgroups? Who is it in particular that was relapsing? And it was actually the group that was more depressed, spent much more time in emergency departments, and were unemployed. Again, I think this finding highlights the need to sort of broaden our focus in therapy to include more attention to occupational functioning and also social functioning. You know, since unemployment is a risk factor, enhanced social supports might help to reduce over-reliance on healthcare, on the healthcare system. So tailoring therapies also can involve looking at moderators of treatment response. I know there's been a lot of discussion about, you know, these therapies aren't any different. They're pretty much all the same and you could choose the same therapy. But the question is, what do we know about whether or not some therapies work better for some patients? The reality is I hear clients all the time saying, I hate a structured approach. I don't want to do a diary card. So there's some people who really probably don't like such an approach and other people who may prefer another approach. So there have been, as I mentioned, very few moderator studies. I've identified 3, and one was conducted at the Karolinski Institute, actually along with Jacques Barber. You'll know this one, and looked at clinical severity as a moderator of response to transference-focused therapy, DBT, or treatment as usual. And they found that lower clinical severity predicted better outcome in the object relation approach, so the transference-focused approach. Now, another study by Anthony Bateman and Peter Fonagy were also interested in the issue of whether or not is clinical severity a moderator of treatment response. It seems like a reasonable question to look at severity as a moderator. They looked at whether or not the severity of clinical symptoms moderated response to a specialist approach versus a generalist approach. And they found that those clients who had higher levels of clinical severity did better in the specialist approach, so the mentalization-based therapy. And then a third study looked at levels of client level of mentalization capacity. And the question was whether or not clients with different levels of mentalization capacity would respond differently to different formats of therapy, and which is an interesting question because we haven't really seen much on that. And they looked at outpatient treatment and day treatment treatment. What they found is that clients who had very low levels of mentalization capacity did much better in the outpatient treatment. And the authors speculated, and it seems a reasonable speculation, that in the context of a day treatment program, these clients couldn't tolerate the constant interactions with other people, that it was too activating of their attachment system. And so they were constantly having to navigate separations and losses. I think what's important is that these findings really highlight that not all therapies are equally effective for all clients. Now, so far, I've focused on single moderators, and we know a single moderator is unlikely to have, sufficient clinical utility when you're selecting a treatment approach. People are complex; they're not just about one particular factor. So, advancements in stats obviously allow for modeling for more complex relationships. We can look at multiple moderators. So in collaboration actually with SPR colleagues, Jack Keefe and Rob DeRubis, we conducted a study using the Personalized Advantage Index methodology. And we applied this to our RCT of DBT compared to general psychiatric management. Again, the interest was to try and identify, are there characteristics that would do better in this psychodynamic approach, the GPM approach, and maybe people who would do better in DBT. So we found that actually clients who did better in the psychodynamic approach were clients who had higher levels of symptoms and higher levels of impulsivity, which is very interesting because oftentimes when people think of DBT, they think of that's a treatment for people with high levels of impulsivity, but that's not what these findings indicated. Clients who did better in the DBT treatment were clients who had higher levels of childhood emotional abuse, higher levels of dependent traits, and higher levels of psychosocial impairment. You can see in this figure here that when clients were randomized to their optimal treatment as predicted by their combined moderator profile, they had significantly better symptom relief. This was on the SCL90 GSI, and this across the follow-up period. So, preliminary evidence confirms that on the basis of these characteristics or client characteristics at a macro level, some people actually do better with certain therapy approaches. So it may be that actually matching patients to specific treatment models might enhance their effectiveness. The caveat is that these studies are very exploratory, they're preliminary, there's a need for cross-validation. Of course, a more idiographic question has been something people have been talking about over the past couple of decades. Hoffman and Hayes asked what core biopsychosocial processes should be targeted with this client, given this goal in this situation, and how can they be most efficiently and effectively be changed? So, of course, one of our major approaches to looking at mechanisms involves looking at mediators. My group has also contributed to this body of research. I'm going to be highlighting some of our research, but also the work of others, and I'll denote our contributions with highlights on the text. So emotion regulation as a construct, which is obviously central to DBT, and I've already told you many studies focus on DBT, this has received a lot of attention. In our early research, we observed that improvements in affect balance was associated with better outcomes, not only in the DBT condition, but also in the GPM. In another study, we found that the effects of DBT skills training on outcomes was mediated by a client's improvement in their ability to tolerate distress. And you can see here, there are other research groups that have also looked at the construct of emotion regulation and found that improvements in emotional awareness, acceptance, also a shift from maladaptive to more adaptive defensive functioning, which we consider to be also an emotion regulation construct, is associated with better change. The other main area that's received a lot of attention is mental states, which obviously figure predominantly in psychodynamic approaches, mentalization-based therapy, transference-focused therapy. They also figure in DBT. So we found that improvements in mindfulness mediate the effects of DBT skills training on outcome. And we looked more specifically also in a second study at different facets of mindfulness, and we found that it was specifically the facet of improvements in the ability to reduce judgments that mediate the effects of DBT skills training on outcomes. Of course, many others, and mostly MBT researchers and transference-focused researchers, have also been studying mental states and have found that improvements in mentalization, improvements in attentional control, and also improvements in metacognition are all associated with better treatment outcomes. Of course, what's really unclear, and I know, Bruce, you made this comment last year, is we don't have any idea whether or not these mental state constructs represent unique information. They may be describing the exact same process. We also need to better understand what the specific relationship is that exists between these processes and the hierarchies between these processes. You know, for example, to what extent is my focus on improving my client's ability to reduce judgment or improve their mindfulness going to help them control their ability to modulate intense negative affect? Also, you can see a lot of this is focused on treatment-specific constructs. And so another important step is going to be to study whether or not therapies work for reasons other than what's been theorized. Now, our group has also been engaged in research on the common factor, the therapy alliance. One of our early studies addressed the question of whether or not personality traits matter when you're matching somebody to a therapy model. Maybe my highly dependent client would be much more likely to follow along and engage in diary cards and homeworks and things like that, but maybe another client wouldn't be. What we found was that in this study that agreeable clients, maybe not surprisingly, did much better in the very structured DBT treatment. They had better outcomes, and that the effect was moderated by the strength of the alliance. So I think these results will highlight that a micro level process like the therapy alliance varies at a macro level, like therapy approach. In a second study that we recently completed, we were interested in disentangling the therapist and client effects. And this is a replication, I don't know if Scott Baldwin is here, but it replicates Scott's work, but extends it by using a time-varying framework, since the alliance obviously changes over time. And in this study, we found that it was the client, not the therapist's contribution to the alliance, that significantly predicted outcomes. And I think this is important because there's a recent study by Del Rey. It's a meta-analysis, and it actually contrasts with findings from that study that found that it was the therapist's contribution to the alliance that predicted outcomes, even in samples of PD. I think the main difference might be the sample. We're looking at 156 clients diagnosed with BPD, whereas the Del Rey study was about 152 clients, and it was a mixed group of clients with personality disorders. I think the quality of the alliance might differ due to different levels of severity in interpersonal deficits. Of course, we need more research to know whether that's true, but that's my speculation. And then in a third study, I want to highlight, this is really spearheaded by Tully Boritz in collaboration with Catherine Eubanks. And this is focused on research looking at ruptures and repairs in clients with borderline personality disorder. So we identified 6 clients in this sample. It's a small sample where we used the rupture and repair or rupture resolution rating system. Applied it to 4 sessions of each of these 6 clients. We had 3 unrecovered and 3 recovered clients. We found that ruptures were quite common in these samples, but we also found that there were a couple of interesting characteristics. First, confrontation ruptures seemed to be much easier to resolve, whereas it was the withdrawal ruptures that were more challenging. Those clients who were unrecovered had a higher likelihood of having more withdrawal ruptures. And furthermore, in the unrecovered clients, withdrawal ruptures seem to persist. So despite the therapist's efforts to try and turn things around with the client, the impact of the rupture seemed to last a lot longer. So I think these findings provide some understanding of how the alliance might actually differ with clients with severe interpersonal problems. Now, if we take all this information, we bring it back to somebody like Norma, is it useful? Or how do we apply it? How does it translate? If we consider how to tailor the therapy to her, first recall I mentioned she's got several comorbidities, including PTSD. She's also got deficits in her ability to regulate her emotions. She's highly impulsive. She's got deficits in her reflective capacities. She's got a very chaotic lifestyle. Her therapist is burnt out. So, first, the fact that she has comorbid BPD and PTSD, given the research, I would expect that actually she'd probably do better in a treatment that is tailored to comorbid PTSD. So there is research that shows DBT for PTSD does better than standard DBT. Now, we also know she's got comorbid substance use. And the problem is we actually don't have any research evidence to guide us on how to select a reasonable treatment approach with somebody with comorbid substance use. So the question is, should we sequence the treatment? Maybe we should refer to an addiction program first and then engage her in a more specialist BPD trauma treatment, or maybe it should be all integrated. These are questions that I think clinicians constantly wrestle with. I mean, these are questions that come up on my consultation team all the time. We're not quite sure what's the best approach. At a more micro level, she actually has a very strong alliance with her clinician. And while this is important, it is insufficient. We know there's other research on looking at the alliance outcome relationship, in particular with substance users, and it shows that the association is quite a bit lower. We also can see she's got several difficulties with impulsivity, emotion dysregulation, difficulties with self-reflection. So there's multiple, I think, relevant processes that a clinician could target. And there's certainly some data to show that it would be profitable to target these domains. However, research is needed to really understand these processes individually and also in interaction in order to determine their effect on outcome. Finally, I mean, so far I've largely been focusing, as I mentioned earlier, on psychological constructs. We really don't have a lot of data focused on biological variables or environmental factors that might support the client's change process. I mean, presumably with somebody like Norma, helping her develop a functional lifestyle that doesn't involve hanging out with people who are drug using would be a reasonable approach to take. It's also reasonable, you would think, that her therapist needs support if she's going to be able to deliver effective therapy. I mentioned she had comorbid ADHD. It would be reasonable that probably a consultation for medication for her ADHD might help and might support the effects of therapy. But there's many gaps in our research. And so it just raises new questions and issues to be addressed. So, scientific progress, of course, it arises through diverse research methods. Both macro and micro levels of analysis allow us to answer questions about how to individualize therapy. There's also, I think, many opportunities to increase our attention to a broader level of analysis. Attention to biological factors and social factors is going to be really necessary to address the complexity of the psychotherapy process. And I think to this end, a much greater collaboration with other disciplines is going to be critical, namely biology, statistics, rehab, psychology will be very critical. Now, in this final section, I want to talk about access to therapy. And again, just to contextualize the conversation, I want to consider a client or a person I've named Tom. And this is actually a parent of an 18-year-old. Again, the picture and the name have been changed. So this is a quote from Tom. "My wife and I are desperate for help with our 18-year-old daughter. Last week, she took a serious overdose and was in the ICU for the past 5 days. She's being discharged next week. Her physicians are saying that she needs DBT, but there aren't any programs in our town, and I don't know where to get help. I'm reaching out to you to assist us in helping her get care." So this brings me to the final tension that I want to focus on. Effective therapies are now available, but they're available to some, and they're also inaccessible to many people. So there's a lot of work to be done in making therapy more accessible to those people who need it. We need to improve access. Obviously, our therapies can't be effective if people can't access therapy. So there's a lot of reasons, why therapy in general is difficult to access, but in particular, why therapy for somebody with personality disorders and specifically BPD are difficult to access. The therapies are lengthy. They're 1 year to 3 years recommended. They're expensive. If you're paying privately, it's probably upward of $30,000 a year. These therapy models I've been talking about, they're complex, they're difficult to implement, they're labor intensive. They aren't necessarily culturally appropriate for some ethnic and cultural groups. And many countries across the world lack any therapists who have any specialist training in BPD specific treatments. So there's no ability to really meet the demand. There's a lack of even generalist therapists. In addition, I think therapists generally aren't trained to work with more severe clients. It's often not a core requirement in many training programs. And for therapists to get training, it often would cost them several thousands of dollars to obtain specialist training. The result is we do have a system that is very inequitable. The result is we have many people who can access therapy, but only if they can pay for it. So we need to think about what are some alternative approaches to making therapy more accessible. These are just a few solutions, but they're not limited to these. We can look at simplifying therapies. We can look at redesigning our therapy services. And we can also think about how we are disseminating psychotherapy. So abbreviating therapy is one solution to the problem of increasing access. There's this long-standing belief that people with personality disorders need long-term therapy. The aim of our second randomized control trial was to address the question of whether a very brief 20-session skills-only intervention would be effective for chronically suicidal clients with BPD. And I was motivated to do this trial after an administrator approached me and said, "You can't offer a Cadillac to all your clients." He was referring to the one-year DBT treatment. Now, when I told the therapist in the clinic that I wanted to do an evaluation of a brief skills-only treatment for chronically suicidal clients, I was met with a lot of anger because they thought it was completely unsafe and unethical was the other word that was used. So they were not on board. I was skeptical. Part of me was thinking, well, I'd provide data, show the administrator that this was not going to be effective. So I definitely wasn't, no bias towards this proving to be helpful. But so the question of this trial really looked at whether this brief intervention could be effective for this population. It was another randomized trial. We compared skills only 20 weeks to an active wait list. So people were engaged in other treatment, but it was non-specific and they were waitlisted for this. There were 84 clients in total. What did we find? We found that the DBT skills group was superior in terms of reducing self-harm and suicidal behavior, and in terms of reducing expressed anger, and in terms of improving coping skills. I think what was important about the study is that it highlighted that brief interventions don't need to be reserved or restricted to people with more mild symptoms, and they could play a role, they could have some benefit to those who were at high risk for suicide. There's now been a growing number of studies looking at brief interventions for borderline personality disorder. A recent meta-analytic study identified 27 different RCTs on brief therapies, and these brief therapies were defined as 6 months or less. The average length was 3 months. A range of models have been tested. About half of them, again, have focused on DBT skills. Overall, the therapies show modest efficacy. Effect sizes range from small to large. The greatest reductions were in the area of borderline symptoms, and effect sizes were twice as high if these interventions were offered as an adjunct to other treatment. So there's still questions that remain about these types of interventions, whether or not the gains made in terms of symptom reduction really are durable post discharge. In another effort to address the question of can we simplify therapy, we conducted a randomized control trial comparing 6 months of comprehensive standard DBT to 12 months of DBT. And we did this study after analyzing our data from our first RCT. So our first RCT, when we looked at the data, actually people were making most of their gains very early in therapy, within the first 4, 5, 6 months. So our question was whether or not would 6 months of DBT be good enough? So we designed this as a non-inferiority trial. So in a non-inferiority trial, what you're trying to do is demonstrate that the treatment's not worse by more than a pre-specified margin. The trial was large. There were 240 clients diagnosed with BPD who are chronically suicidal. And what did we find? We found that actually the non-inferiority hypothesis was supported for our primary outcome, which was total self-harm, so large effect sizes. We also found that non-inferiority was supported for general psychopathology as well as for coping skills. So what was also interesting is that tests of superiority showed that those participants who got randomized to the shorter treatment actually made more rapid gains in terms of reducing their borderline symptoms and reducing their general psychopathology. So it also, raises this question of actually, maybe there's benefit of having these shorter periods of treatment, in that it might help to accelerate people's engagement in the treatment. Now, we also found that there was no evidence that the longer treatment was superior on any outcomes. And so I think this highlights that potentially a shorter treatment might be a way to reduce barriers to access. Of course, the interest in this trial wasn't just to see whether or not DBT 6 months versus 12 months would be non-inferior, the 6 would be non-inferior, but we were really interested in knowing what dose would work for whom, because I feel every day in the clinic, we're sort of making decisions about, do we, assign this person to a shorter treatment or a longer treatment? There's limited resources for people. So we've begun to look at moderators of dose. And the first trial looked at neurocognitive functioning. So specifically, we were looking at a performance-based assessment of impulsivity using the Conners performance test. We found that those clients who had the highest levels of impulsivity actually seemed to respond better to a shorter treatment. In a second study, and this study I want to highlight was conducted with Sebastian Uhler, Uli Kramer, Anna Babel, and also with consultation with Chris Perry, who I see back there. And it was supported by an SPR collaborative grant. So thanks to SPR for that. But we were interested in looking at whether or not defensive functioning would moderate response to dose. So we assessed defensive functioning using the defense mechanism rating scale. What did we find? And this was a subsample. It was 60 people, 30 from each arm of the 6 and 12 months. We found that actually those individuals who the longer treatment was optimal for were the clients who had the highest levels of immature defenses. In other words, those who had more borderline type defenses really required the longer treatment. So again, these findings provide some preliminary evidence for choosing between a shorter or a longer therapy. There's a lot more work to be done. We're collaborating right now with Jack Keefe doing another personalized advantage index analysis of this data. Now, a second way to improve access is we can reconceptualize how we're organizing our treatment. And there's a couple of directions I want to highlight. One is stepped care, stage care models. So in step care, you're starting somebody with the briefest first, and then you move them up as necessary. Stage care, you're trying to match them to the optimal level of intensity first. And a really nice example has come out of Australia. It's a very brief intervention. It was a 4-session intervention that was conducted in a crisis service for people with personality disorders. Huxley was the PI. I know Bryn Grenier is a co-investigator on this trial. But I think what was nice about this study is that the brief intervention was actually quite impactful in terms of helping people reduce their symptoms. And it helped people get out of crisis and become a little bit more stable symptomatically. So I think it it highlights that there is a role for these brief interventions. Our group is actually in the midst of replicating this in Toronto in our emergency department. In a second approach to how we might think about how do we reconceptualize services, a second approach involves leveraging support from non-specialists to bridge the gap. And here I want to highlight, I think, some excellent examples, and these are outside of the field of personality disorders, but in particular, I'll highlight a program by Vikram Patel, and it's the Healthy Activity Program, several studies have been conducted on this, but one very large-scale RCT demonstrated the effectiveness of using non-specialist health workers in the treatment of depression in India. And I think what's really important is that these are clients who wouldn't have received any treatment whatsoever. So having a non-specialist provide support and having it be helpful in terms of reducing the severity of the depression was really important. So training families is another way to expand the circle beyond specialists. In the following study, we evaluated the feasibility of a skills-based intervention called Family Connections. Originally, it was designed for families of people with BPD. We adapted it for caregivers of youth who had significant addiction and mental health problems. We engaged 94 different caregivers across very remote northern communities in Ontario, as well as in Toronto. And the intervention, interesting, was delivered not only by professionals, but also by caregivers. We trained up a group of caregivers and they facilitated the intervention. What we found is that caregivers reported reduced, oops, that was too early. They experienced reduced burden, reduced grief, and reduced stress. We also included a qualitative component to this methodology because we were interested in the experience of caregivers. Just to share, one theme that emerged was, and this was the caregivers really saying that their increased ability to respond to their youth was critical. This is in the words of one participant. It's not, what do I need to do now? It's more, you're having fun and you feel like you're going to be left out. That must be really difficult for you. Those are things I wouldn't have really thought about at other times prior to this training. So I think this type of intervention has potential to have broader based benefits. And finally, the third area, just to highlight in terms of ways to increase access, is how we disseminate psychotherapy. The pandemic has obviously radically changed how we're using technology, and up until really 3 years ago, we weren't utilizing it in the same way that we are. Often historically and really traditionally, our methods for training therapists involved going to a workshop led by an expert, obtaining supervision, and that's been the standard for the past 40 years. However, there are obviously many other ways. Long before the pandemic, people like Chris Fairburn, as an example, has been engaged in wide-scale use of technology and really sort of spearheading technology as a way to make training of therapists more scalable. Another really nice example just to highlight is one by Raman and colleagues. They successfully used technology to train community health workers in northern Pakistan to implement what they refer to as a Thinking Healthy program. And it's a CBT intervention for perinatal depression. There's actually another trial currently underway in North America. It's the largest of its kind on perinatal depression. And it's utilizing the same principle of actually training up non-specialists using technology to treat perinatal depression. So since 2018, I've been part of what's called the ECHO Ontario Mental Health Program, and we've been focusing on trying to train people in evidence-based approaches in the province of Ontario. ECHO was a model that was actually originally created in New Mexico, and the goal of it was to try and enhance training in underserved communities to address healthcare shortages. So it has been utilizing web-based technology for some time. We've been training clinicians in CBT and DBT and trauma-informed care. I've been heading up the DBT module, and we've trained hundreds of healthcare providers, so not necessarily specialists. And the outcomes are that healthcare providers report high satisfaction, improved knowledge, and improved confidence. In the words of one participant, there's a primary care provider, I received minimal training on how to effectively support a client's mental health in a non-pharmacological manner, especially with complex situations. The ECHO session truly helped me gain a better understanding of the psychotherapy process and how to incorporate it into my practice so that I can provide meaningful supports to my clients. So returning to Tom, does any of this evidence directly translate to his situation? Keep in mind, Tom has no access to specialist care. Even the generalists in his community are untrained, and there's no supports for him. He could be encouraged to enroll in a virtual family connections program, because we now have those. I mean, they're now running wildly across Canada and elsewhere in the world, with families spearheading those groups. It may be that the generalist healthcare providers in his small remote community might get engaged in something like the ECHO DBT, where they could use, gain some skills on how to work with somebody like Tom's daughter. And given the very limited healthcare resources in this community, actually it might be ideal for those practitioners to consider implementing and learning a very easy to adopt model, such as a skills-based intervention, because probably something more complex might be a little bit more challenging. So there's many ways to improve access. We can offer briefer therapy even for complex clients with benefits. Our therapy programs can be based on stage models and informed by evidence from moderators of treatment length. We can leverage support more from non-specialist providers, and we can also expand upon our digital training, especially with non-specialists, to bridge the gap. So to wrap things up, there's obviously a lot of dialectical tensions in psychotherapy research and practice, and I've highlighted only a few. I think as our understanding of psychotherapy just becomes more complex and more ideas emerge, there's more tensions that will come up. I think these points of tension pose great opportunities because they're a place that we can build some bridges and consider some diverse perspectives to advance our thinking. By recognizing these points of tension and also looking for what's the synthesis between these emergent perspectives is, I think, one way to advance our science. Now, I think that the dialectical tensions that I've highlighted, they also point to opportunities to broaden and deepen our understanding of psychotherapy. So we can, I think, benefit from increasing a focus on diverse and understudied populations. I think we can continue and even more actively embrace diverse methods, especially in same studies, and increase our understanding of how to optimize psychotherapy. I think greater interdisciplinary collaboration, as well as considering a broader level of analysis. So such as focusing on environmental factors and biological factors will be critical. And finally, simplifying therapies, reconceptualizing how are we delivering therapy programs, and digital training of non-specialists will be, I think, some ways to improve access. So at the outset of my talk, I began saying that science advances through a dialectical process. All psychotherapies inherit ideas from the past. We change them up a bit and we pass them on to the future. And I want to end with a quote from Hegel. We learn from history that we do not learn from history. And that's a dialectic. So thank you.